All right, this is our review of Lab 10, sole foot and joints of the lower extremity. We are starting by looking at the plantar muscles, which are the muscles in the sole of our foot, and we have 4 different layers of these muscles. So we have a nice mnemonic, a memory palace from the Memorized Medical YouTube channel, and we're going to just work our way up from most superficial, meaning towards the skin of the foot, to deep, closer to the bones of the foot. All right, and so first off, our first level of our memory palace, the small, is the store Abercrombie & Fitch, and so AB stands for abductor digiti minimi and abductor hallucis. F is for flexor digitorum brevis, and let's just take a quick look. So in the center we have flexor digitorum brevis, then we have abductor digiti minimi, and we have abductor hallucis. And then our second layer is the garden center, and this is going to be full of worms and plants. And so we have the lumbricals and quadratus plantae, and the flexor digitorum longus tendon, not to be confused with the flexor digitorum brevis, which is on the level below. But lumbricals, remember, was Latin for worms, or derived from Latin word for worms, and then that's going to have its origin on the FDL tendon, and quadratus plantae is going to have an insertion on that tendon. So let's just take a look. So we go ahead and hide this, hide level 1. Okay, and so here we have the lumbricals, that one, the lumbricals right there. And you can see that they have an origin on the tendon of the flexor digitorum longus, which is coming from the posterior part of the leg. All right, which is our Tom, Dick, and Harry, if you remember. All right, then we have our quadratus plantae, which is inserting on the tendon of the FDL. All right, let's look at our next level, which is an incoming 7-11, and we have 3 muscles here, and they kind of look like the looks like 7-11. So we have adductor hallucis, flexor hallucis brevis, and flexor digiti minimi. And let's take a look at those. All right, so I'm going to hide our lumbricals, I'm going to hide the FDO, and I'm going to hide the hallucis longus. And all right, let's just take a look here. We have our adductor hallucis, the 7. We have our flexor hallucis brevis, and then our flexor digiti minimi right there. All right, so I'm going to go ahead and hide those so we can get ready for our next level, the 4th one. All right, which is going to be our interosseous muscles. And so in the 4th level of our memory palace, we have the interoffice space, and we just like with the hands with the interosseous muscles, we have pads and dabs, and the mnemonic for those is still the same. So pad is palmar interosseous muscles, and dabs is dorsal interosseous muscles, and pads do adduction, and dorsal interosseous muscles do abduction, bringing the toes inwards towards the center line. All right, in terms of innervation, we have the sciatic nerve from sacral plexus. It's going to go down and split, as we said previously, become confibular and tibial nerve. The tibial nerve in particular is going to go through the tarsal tunnel and give rise to the medial plantar nerve and the lateral plantar nerve. And so for medial plantar nerve, we have a mnemonic LAFF, L-A-F-F. That's the first lumbrical, the medial lumbrical. A is abductor hallucis, which is from our first layer. Flexor digiti brevis, digitorum brevis, and then flexor hallucis brevis for medial plantar nerve. All right, and then let's just take a quick look at those interosseous muscles. So we have plantar interosseous, and then deep to those, we have our dorsal interosseous. Let's see if we can get a good view of those. All right, plantar interosseous, dorsal interosseous muscles. Okay, so that's our 4 layers of the plantar muscles, and let's just quickly take a look at the bones of the feet. All right, so bones of the feet, we have the talus, which is going to articulate with the tibia and fibula. Below that, we have the calcaneus, which we're very familiar with, the heel bone. We have the navicular, the cuboid, then the cuneiform bones, 1, 2, and 3, medial, intermediate, and lateral. We have our metatarsals, and then we have our phalanges. Okay, we mentioned the plantar aponeurosis. This is the thickening of the plantar fascia that covers this region, and its clinical significance. I know I in particular have had plantar fasciitis before, which is inflammation and tearing of the plantar aponeurosis. Okay, so we went over the first layer of the muscles of the sole of the feet. This is Abercrombie & Fitch, abductor digiti minimi, abductor hallucis, and flexor digitorum longus. So that's these 3. And then what is their innervation? Well, we have LAFF, and as a mnemonic for the median plantar nerve, and so A in LAFF is abductor hallucis, and flexor digitorum brevis is one of the F's, and then everything else is lateral. So the abductor digiti minimi is lateral plantar nerve, and their names pretty much tell you what they do. So abduction, and then flexing of the digits. All right, second layer, we have the garden layer. This is our lumbricals and our quadratus, and our lumbricals are the first part of our mnemonic for the innervation of this region. So L for LAFF, and it's just the first lumbrical. It's the first medial plantar nerve, and the other is the lateral plantar nerve, and then quadratus plantae is from the lateral plantar nerve. And then what do they do? The lumbricals are going to flex the metatarsals and extend the joints in this region. All right, then we have the quadratus plantae. This is going to pull, straightens the pull of the FDL tendon, right, as we have the FDL tendon is coming through the tarsal tunnel, and it's going to be pulling on the digits to flex them, and so the quadratus plantae is going to ensure that this pull happens, straightens out that pull. Okay, then you have the 3rd layer, which is our 7-11. So we have our adductor hallucis, which is lateral plantar muscle, flexor hallucis brevis, which is one of our LAFF mnemonics. So that's medial plantar nerve, flexor digiti minimi brevis. Again, the names of these muscles tell you what they do, so not too bad. All right, then we have finally our interosseous muscles, and we have pads and dabs. Dabs is more dorsal, so towards the top of the feet, and pad is palmar towards the sole of the foot, or like the palm of the hand. All right, and then these are lateral plantar nerves. Again, the lateral plantar nerve is coming from the tibial nerve. All right, so what arteries supply the sole of the foot? The posterior tibial artery, again, coming from the tarsal tunnel down here, is going to branch out and form the lateral tibial artery and the medial tibial artery. And so we can see that here and here. And that's going to be doing our innervation, but the tarsal tunnel is going to go from leg to foot. Remember, Tom, Dick, and a very nervous Harry. All right, so branching pattern for a cadaver. I didn't do this particular dissection myself, so I'm not exactly sure. And our lab group struggled with this, but apparently there's 2 different branching patterns. It's just important to remember our tarsal tunnel, though, is going to give rise to our artery and nerves in this region as well as the veins. Okay, nervous innervation of the sole of the foot. Again, tibial nerve is going to branch into the medial plantar nerve, lateral plantar nerve. Then you're going to get the deep and superficial branches from the lateral plantar nerve. And you can trace their innervations overall, but medial is more on the medial side, lateral is more on the lateral side, which is nice. Good naming. All right, summarized sensory motor tests involving the foot. Well, remember the lumbar sacral plexus is L4 through S4, and so in terms of testing this, I think this is just kind of a memorization thing, but I think from top to bottom, L4, L5, S1. So it kind of looks like if you write it this way, top to bottom, which is nice. Then we know, of course, from the tarsal tunnel, we have the tibial nerve that's splitting to lateral plantar and medial plantar nerve. Saphenous nerve is from our femoral nerve. It's the terminal end of the femoral nerve, so not too bad. And then we know the fibular nerve is, the superficial fibular nerve is coming from the common fibular nerve, which is coming from the sciatic nerve, and that will also give rise, a branch of the common fibular nerve will give rise to the sural nerve, and then the deep fibular nerve also comes from our common fibular nerve. All right, not too bad. And then we have testing. These are something you'll just have to write down a few times, unfortunately. All right, can you describe the important structures of the hip joint? All right, well, we have our hip joint is focused on the acetabular foramen, and around that we have the so we have the acetabular fossa, the labrum around it, forming the socket. We have the posterior, or the inferior part is from the transverse acetabular ligament, and then you can see the head of the femur is going into there. We have the obturator artery. And then superficial to all of this, we have various ligaments. We have the iliofemoral ligament, and this is considered the toughest ligament in the human body. We have the pubofemoral ligament, and then the ischiofemoral ligament. And the nice thing is these are all named, these ligaments are named according to the structures that they connect. So if we're wondering, what is the possible name of that, can we ID the bone that they're connected to, or the part of the bone? And if the answer is yes, then we can tell ourselves the name of the ligament. All right, so what about the fractures of the femur? Can you differentiate between intracapsular versus extracapsular? Well, intracapsular is going to be anything associated with the neck. So we have subcapital neck fracture right here. Then we have transcervical fracture right here. And these are the fractures that are going to give us a hip replacement because we have terrible blood supply to this region. And then extracapular are anything that's intertrochanteric. So anything that's not on the neck of the femur. All right, and so we have one fracture right here. We have another fracture right here. This is going to put the blood supply at the head of the femur at risk. Why would that be the case? Well, let's just take a look at the blood supply. So what is cruciate anastomosis? Basically, we have if the common external iliac artery, which gives rise to the femoral artery, or the proximal femoral artery are blocked, you have alternative ways for the blood to get to the rest of the lower limb. And so in particular, you have the superior gluteal artery, the inferior gluteal artery, which will anastomos with the lateral femoral circumflex artery, medial femoral circumflex artery, and then, of course, the first perforating artery of the deep femoral artery branch. All right, so not too bad. Bony structures that articulate the knee joint. We, of course, know the patella, the kneecap, aka the kneecap. We have our medial and lateral meniscuses. We're going to see the PCL, of course. We have the ACL. And we are going to look at those a little bit more. All right, we have the IT tract coming and inserting in on the tibia, the fibular collateral ligaments, the tibial collateral ligaments, the patellar ligament, quadriceps femoris tendon up here, and then posteriorly we have the oblique popliteal ligament. Okay, and this is a cut of the knee. In particular, this looks like we are looking at the anterior portion of the knee. In particular, we can start to see the ACL and PCL here, and we have the patella, we have the lateral meniscus, we have the medial meniscus. And yeah, I think those are the important parts to point out. Here we have the infrapatellar fat. We have a couple of bursas. Prepatellar bursa, it's on top of the patella, so it's well named. Then we have the infrapatellar bursa, which is below the bursa, also well named. And then the suprapatellar bursa, which is above the patella, so that's nice. Then we have our ACL and our PCL. Our ACL is preventing forward displacement of the tibia, right, tibia. And the PCL is preventing posterior displacement of the tibia, right? If I were to pull this way anteriorly, the ACL would be in tension, and if I were to push backwards against the tibia, the PCL would be in tension. Right. Baker's cyst is when you have a cyst here from the extension of the subpatellar bursa, the synovial fluid in our cavity going outwards. Okay, our unhappy triad, it's worth mentioning. Common injury, if you're tearing your ACL, you're probably going to have an injury to the tibial collateral ligaments, right, which is going to be right here on the medial side of your leg, and then the medial meniscus, which is right here. So this is a member of the unhappy triad, the medial side, and then our ACL. Okay, and ACL, if we wanted to test, there's a couple of different ways. So we said that it's going to keep the if I were to pull forward, right, there's the anterior drawer sign for the ACL. If the ACL is broken or torn, you'll be able to pull the tibia out in the anterior direction. In PCL, it's the opposite. If the PCL is broken, you can push this way, and you should be able to push the tibia in, and therefore you can know it's broken. For the meniscus, there's a couple different ways of doing this, but the one that I like is you can do it on yourself is Egge's test, EGE. And so basically, to test the medial meniscus, if you have your feet facing medially inwards, and you do a squat, and if you feel pain or hear popping, typically that means that your medial meniscus is torn. And the exact opposite, if you have your feet, your toes pointed laterally, and you do a squat, you'll put extra strain on the lateral meniscus, and you can tell if the lateral meniscus is something wrong with it. And then there's another test that you can do. I'd recommend. It's the McMurray test, but this one you have a second person. Typically the physician does this test on somebody else, and it's hard to describe, so you'll have to watch it on YouTube or something if you'd like to do that one. All right, so we have Netter's drawing of the knee. In particular, it looks like we are looking upwards, right? So looking upwards at the knee joint, and we can see this is the femur right here with the lateral side and the medial side. We have the ACL and PCL right there. We have the fibula, which we know is lateral, and then the tibial collateral ligament. Then if we're looking down at the tibia, we have the lateral meniscus, medial meniscus, and we can see which meniscus has a wide positioning of the anterior and posterior horns. So that's these guys. Well, it is the medial meniscus right here. Medial meniscus, which has a wider positioning of the anterior and posterior horns. All right, what is the proximal attachment? Is the proximal attachment of the ACL more medial or lateral on the femur? All right, well, so here's the proximal attachment, and that would be on the lateral side, so it's more lateral on the femur. Okay, looking at the knee joint with an MRI, we have in this region the PCL and the ACL. Honestly, I think this is just going to take some practice looking at these. The lateral meniscus versus medial meniscus. How could you know these ones? That is a great question. Hopefully we'd have a little bit more to go off of, such as, the tibia is always a great way of knowing if you're lateral or medial. And so those are the points that we can see. We have our patella here. Looks like we have our bursa, and yeah, it's not too bad. Okay, so this is having to do more with the meniscuses. Genu varus is this one right here, and that's the bow-legged situation where you have extra pressure on your medial meniscus, and your fibular collateral ligament, you can see, is stretched. Here we have our knock-knee situation, where you can see that the lateral meniscus has extra pressure, and our tibial lateral ligament is stretched. Right, and so knock-knee is valgum, and bow-leg is varum. Okay, bones of the ankle joint. We have the fibula and the tibia, and they're going to articulate with the talus. We have the medial malleolus, which we know is going to have the tarsal tunnel coming under there, and then the lateral malleolus is going to have the tendons from the lateral compartment of the leg. Okay, in what position is the ankle joint most stable? It's when the foot is dorsiflexed, so as if you had just pulled your foot off of the gas. And what is a high ankle sprain? That's a torn anterior tibiofibular filament being torn. So if this guy is torn, it's a very strong filament, that would be a high ankle sprain. And then the ligaments of the ankle joint, we have the deltoid, aka medial ligaments of the ankle joint, which is just all these guys. And so these are all names according to the bones that they connect, so that's nice. And then we have the lateral ligaments, and again, named according to the bones that they connect, which is nice. What ligament is most likely to be damaged? The anterior talofibular ligaments. This guy tends to be hurt easily, but basically our eversion and hurting of the lateral ligament is the most common. As you can see, these are all separate and fairly thin, whereas our medial deltoid is quite thick. Okay, what about the important joints of the foot? Well, we have our hind foot joints, which is this guy right here. Then we have our midfoot joints, which are these two right here. And then we have our forefoot joints, which are those guys right there. And if we're looking at the subtalar joints in particular, that's this guy right here. That's our hind foot joints. This supports foot eversion and inversion. And then we have our Lisfranc joints. Lisfranc joints is our tarso-metatarsal joint, which is this guy right here, and that is going to support midfoot stability. Okay, so not too bad. We have our tarso-metatarsal joint right here from our tarsals and our metatarsals, and then we have the transverse tarsal joint behind it between the talus and the so-called tarsals. All right, then we have the different arches of the foot. We have the medial longitudinal arch, the transverse arch, and then we have the lateral longitudinal arch, which is hard to draw here, but you can kind of see it right there. In terms of the ligaments that are supporting the arches, in particular, we have the plantar aponeurosis. We have the short plantar ligament, the long plantar ligament supporting this medial arch, and then the plantar canionavicular ligaments, and then we have a couple of tendons, or three tendons in particular, the tibialis anterior and posterior ligaments, and then the fibularis, the longest ligaments. And so when we have flat-footedness, typically this guy is failed, or you might have stretching of the various tendons. Okay, so that's it, and we'll take a look at the surgical case, and then we're done for the slide review. All right, so this is our surgical scenario for Lab 10. We have Haley, a 23-year-old female presenting with pain and tenderness in her left ankle. She's a student athlete who twisted her ankle in an inversion injury after trying to block a goal. She now complains of redness, swelling, and difficulty bearing weight on the injured ankle. Her x-ray is shown below. After evaluation and imaging, her physician determines the fracture is unstable and requires an open reduction internal fixation operation to stabilize the ankle. She's instructed to avoid bearing weight on her injured foot for at least 4 to 8 weeks post-op and must wear a controlled ankle motion boot until reassessment. While this is a common injury, especially in sports, proper care is necessary due to risk of non-union and avascular necrosis. What type of fracture did the patient most likely suffer? All right, well, so I sort of highlighted it here, but you can kind of see there's a fracture here on the fibula and then a fracture here on the medial malleolus, and so it would appear that she has a bimalleolar ankle fracture, and says it requires surgical intervention and 4 to 8 weeks of healing before reuse. What are the main bones and ligaments that are affected by this injury? Well, the ankle joint is made up of the tibia, fibula, and talus, which articulate with each other and supported by ligaments. The medial collateral ligament, which is over here, is made up of 4 separate ligaments that overlap and stabilize the ankle joint by securing the tibia to the foot. Although strong, less prone to damage as compared to ligaments of the lateral ankle region. The deltoid ligament can be ruptured in injury following foot eversion or external rotation. All right. So basically, the deltoid ligament will, even though it's quite strong, will rupture if you have basically excessive foot eversion or external rotation. All right, good job. That's the end of Lab 10, and see you guys in Lab 11.